A 32-year-old pregnant woman was examined by a gynecologist who observed that she had hypertension. The doctor felt concerned and immediately thought of impending eclampsia with her high blood pressure reading. If the doctor during the antenatal checkup had cared to ask her one very simple question, "What exactly is the work you do?" she would have found out that the hypertension in this young woman could be work-related. Active history taking has long been identified as a core discipline in treating patients. Spending more time compiling a good patient history has been known to provide the most benefit as compared to long physical examinations and expensive laboratory tests. Collecting an incomplete history can affect initial therapy and all subsequent decisions for treatment. Therefore, it is essential that primary care physicians ensure that neither the patient nor the health system is unduly burdened by deficient history taking. India is one of the major producers of salt, accounting for 8% of the world's salt production. Gujarat, Tamil Nadu, Rajasthan and Andhra Pradesh are the leading salt-producing states of the country. Gujarat alone contributes around 70% of the total salt production in the country. Thoothukudi district in Tamil Nadu alone is the second largest producer of salt in the country after Gujarat. India's salt industry is labor-intensive and provides employment to about 20 million people. Apart from a few who are employed by large companies, most of them operate on a no-work, no-pay contract for 8 months a year. Several thousands of other workers depend indirectly on the salt industry for their income. Distribution of workforce. There are 3 kinds of salt workers in India, depending on the type of location and the pattern of entrepreneurship. 1. The worker may be hired by a land leaseholder who owns a salt pan. 2. The worker may be hired by a manager or a labor contractor on behalf of the leaseholder. 3. The worker may be subleased out to the salt worker with a buyback system. Salt workers in the organized sector are relatively better off, but the workers in small salt pans are worse off as far as working conditions go. Characteristics of work. 1. Salt pan workers work under extremely harsh conditions that lead to constant exposure to sunlight and UV radiation. 2. They do not seem to have access to sheltered places near the salt pans, in most cases, and also suffer due to the bright light reflected from the salt dunes. 3. Availability of basic amenities such as toilets, housing, drinking water, and sanitation is lacking. Most often, persons may not have a proper shade to have their meals. 4. People may go without proper food or water during working hours, and this may also predispose them to poor or impaired nutrition. Methods of work or operations involved. Salt pan workers usually adopt the following salt production life cycle. 1. Every year during January and February, salt pans are prepared. This process comprises mending of bunds, desalting of channels, and preparing the crystallizer bed. 2. Salt pans are then prepared with a special slope in one direction to drain water into the successive pan. 3. Once the salt pans are ready, seawater is pumped into it. The water starts evaporating, and this concentrated brine is then diverted to the next pan By the time it reaches the last pan, the evaporation is complete and sodium chloride crystals are left behind. 4. The crystals which separate are collected by wooden shovels with long handles. This process is called scrapping of salt. 5. The salt thus formed is then carried overhead in baskets and stored in a central place or platform till they become dry. 6. Later, the workers fill the salts in gunny bags, weigh them and load them into trucks for transport. 7. Salt workers engage in various processes of salt manufacturing like A. Sweeping the salt crystals with a wooden spade. B. Heaping of salt crystals at edges of planes. C. Loading. D. Weighing. E. Milling. F. Packing. G. Transportation of salt. Health problems and disease patterns. Workers in salt pans are prone to a large variety of health problems and the workers are at high risk. The following health problems are most common to workers in salt pans. 1. Chronic dermatitis and ulceration due to contact with sharp salt crystals, especially on extremities. 2. Eye problems due to exposure to bright, white, reflected light and dust, leading to loss of vision or pterygium. 3. Increased risk for hypertension, high blood pressure, probably due to inhalation of salt aerosols. 4. Ailments due to poor socio-economic conditions, malnutrition, anemia, vitamin B, A and D deficiencies, manifested by symptoms such as headache, giddiness, breathlessness, muscular and joint pains, deterioration of night vision, and accelerated aging. 5. Back and shoulder pain, which may be due to carrying heavy loads. 6. A predisposition to hypothyroidism, especially in women, which may be due to ingestion and exposure to non-iodized salt. Dermatological conditions. Contact dermatitis, skin cracks and ulceration. Causative source. Exposure to chloride in salt crystals, irritation due to the high concentration of salt and the irritating environment, humidity, high pH of water and the wet environment that prevails in the salt pan environment. Dry skin, sunburn. Causative source. Strong sun exposure, UV and white sunlight exposure. Subungual melanoma. Causative source. Constant exposure to white sunlight and UV radiation. Gangrene. Usually starts with shrunken skin, leading to dry gangrene. Causative source. Insecticides, arsenic, irritant dust, ammonia, fumes. Ophthalmological conditions. Premature progressive loss of vision. Workers are exposed to glare and develop redness of eyes, burning sensation in eyes, and excessive watering in eyes. Cataract. Causative source. Constant exposure to bright, white sunlight, UV radiation exposure, and dust. Nyctalopia. Loss of night vision. Causative source. Nutritional deficiency, particularly A vitaminosis A. Circulatory conditions. Hypertension. Causative source. Higher salt content in their blood from inhalation of salt aerosols. Heat stroke. Causative source. exposure to heat and working in humid conditions. Musculoskeletal conditions. Strain injuries. Occupational cervico-brachial disorders, OCD, repetitive strain injury, RSI, cumulative trauma disorders, CTD, overuse injury syndrome, work-related neck and upper limb disorders. Causative source. Most of these conditions are caused by mainly awkward and unnatural postures, repetitive strenuous movements without rest periods, and lifting heavy weights. Prevention and control of health hazards and welfare of salt pan workers. Many study groups have recommended some measures to improve the overall working conditions of salt pan workers. 1. Improve workplace amenities such as A. Access to potable drinking water. B. Mobile clinics. C. Protective gear like gloves, shoes, sunglasses, etc. D. Sanitation rest sheds. E. Strengthen awareness on family planning. F. Recruit health workers from the salt workers community. 2. Set up child creches and schools. Mobilize NGOs for the purpose. 3. Modernize the industry without marginalizing small-scale salt units. 4. Standardize production techniques. Preventive interventions require strategic contribution and efforts from government through occupational health and safety policy and legislation, cooperation from employers as well as workers, and advice from medical professionals. Occupational diseases manifest after long latency period from the time of exposure. There are challenges to establish and declare that a disease is due to hazard at workplace. Elaborate guidelines for management and prevention of occupationally caused diseases is beyond the scope of this documentary, as currently there is no mechanism for doctors to enforce their recommendation without a statutory backing. We therefore give general principles of prevention. Preventive measures should be designed and implemented at 3 levels of prevention. 1. Primary prevention aims to reduce the occurrence of disease by eliminating the cause of disease, for example, use of benzene-free solvents or solvent-free paints to eliminate the risk of carcinogenicity, or reducing exposure to safe levels that prevent it from causing damage, for example, reducing noise at its source to levels that do not cause noise-induced deafness. 2. Secondary prevention to identify and treat health problems as early as possible, often before symptoms have developed, in order to take corrective action. For example, regular audiograms among workers exposed to high levels of noise in the work environment. 3. Tertiary prevention aims to avoid complications of and disability from illnesses and injuries and/or to provide rehabilitative and palliative care. It aims to minimize the consequences in persons who already have disease and depends on appropriate treatment. We expect that the primary care physicians are already well versed with clinical knowledge for management of the occupationally caused health conditions. To learn more about detailed clinical perspective, treatment and prevention and control, please refer to e-book or printed version of BOHS for Informal Industry, Manual for Primary Care Providers. So, if your next patient with any of the presenting symptoms we described earlier comes for treatment, please don't forget to ask him the $1 million question. What exactly is the nature of your work?